All right, thank everyone for joining us here for this webinar this afternoon on pandemic ethics. This is something that a lot of you are either dealing with right now or will be dealing with very soon. So we are grateful to you to be here today, and then also to our panelists, Jeanne Wirpsa and Tim Usset. So my name is Michael Skaggs. I'm the Executive Director of the Chaplains Innovation Lab, and we are co-sponsoring this webinar with Transforming Chaplaincy. So we're very happy to be here together. And I'm just going to give sort of a quick technical rundown of what we're doing here, and then I'll turn it over to George to explain a little bit more detail of the content of what we're doing here today. This webinar is being recorded, and so if you have to leave early, that's no problem. Within the next probably day or so, this will be available. We'll have it up online, and then you can share that with whomever. There's no sort of restriction. This is a free resource for everyone. So if you do miss it, no big deal. You will notice on the right-hand side of your screen in the little bar of the GoToWebinar window, there's a little thing that says questions. And so as things come to mind, as we're in the webinar, type your questions in there, we will see them, and then somebody will answer it in one form or another, either live right here while speaking or typing an answer in. So we'll have that availability as well. And then there's the chat function that you're free to use at the same time, but we'll be monitoring the question box. Those are the technical sort of details. If you have any more questions that you have, you can find me over there in the attendee list. You can send me a message and I'll do what I can to help you out. But until then, I will turn it over to George.
Thank you, Michael. Michael, while I'm talking and doing the introductions, maybe you can put up the slide that has the prayer on it. So friends, this is George Fichette from Transforming Chaplaincy. We're very happy to be co-sponsoring today's webinar with the Chaplaincy Innovation Lab. While I'm doing the introductions, you'll see a prayer here that was written by our colleague, Chaplain John Eman. John is a chaplain at Penn Presbyterian in Philadelphia and a senior research fellow with Transforming Chaplaincy. And this is a prayer that he wrote for his colleagues at his hospital and distributed yesterday. As I'm doing the introductions, you may appreciate an opportunity to kind of be in a moment holding in the light, as we say in the Quaker tradition, all those who care for the sick and suffering, their families, and all those who are affected by the pandemic. It's our pleasure to present today's webinar. And our presenters are Jeanne Wirpsa. Jeanne is the program manager and clinical ethicist for the medical ethics program at Northwestern Memorial Hospital in Chicago, where she is also a board certified chaplain and a research chaplain in the Department of Spiritual Care and Education. Among other things, Jeanne co-facilitates the Religion, Bioethics, and Medicine course and the McLean Center for Clinical Ethics at the University of Chicago. And I'm very pleased to say that Jeanne is co-editor with our colleague here in Chicago, Karen Pugliese, of a new book of chaplain case studies. The book is entitled Chaplains as Partners in Medical Decision-Making, Case Studies in Healthcare Chaplaincy. The book is published by Jessica Kingsley, and if you go on Amazon today, you can get a copy. 9 really interesting, informative case studies with critical commentary by other chaplains and healthcare providers. Jeanne, congratulations on that. It's a really important contribution to our profession. Presenting with Jeanne this afternoon is Tim Usset. Tim is now the Executive Director of Physicians Serving Physicians, which is an organization in Minneapolis that works on supporting physicians' wellness. Tim is also an Army Reserve chaplain and past Transforming Chaplaincy Research Fellow. Tim's research has focused on the treatment of PTSD in military veterans, where he has collaborated with clinical psychologist Irene Harris on the development and testing of an intervention, a spiritually based intervention called Building Spiritual Strengths. And so we're very happy, Jeanne and Tim, to have you here to share your expertise as we're all concerned and thinking about how to provide care in the context of the pandemic. Jeanne, I'm going to turn it over to you.
Okay, I'm going to do my best to get the screen up. Can you all see the slides and me?
Jeannie, I'm going to make you the presenter, and that should
Okay.
that should bring up your screen there.
Okay. Seem to have a lot of things on it. Can I just show the Microsoft PowerPoint?
Yeah, that should work fine.
Okay. Tell me when we're good to go.
I don't see it yet. Let me bring it up on my screen here.
While Michael's doing that, I'm going to go ahead and get started. And let me just say, in full disclosure, I have been actively involved with our Northwestern medicine system in planning for this pandemic and providing ethical guidance for our bedside providers. It is a tremendous load to carry. And part of why I and other folks in our system who are trained to provide this kind of leadership are doing that is so that bedside providers will not have to bear this moral burden alone. And that's a lot of what we're going to talk about is the shifting framework that we use ethically when talking about ethics during a pandemic, but also, again, the moral injury and insult that our providers experience during this time. And again, even if we have set up the system so that others are ultimately making difficult allocation of scarce resource decisions for our bedside providers, we know that all of us, chaplains included, are impacted by these decisions, are witnessing them, are holding up the people who are making them, are again responding to families and patients when difficult choices have to be made. So just acknowledge that. I also want to recognize that there's chaplains from all around the country here, and some of you are not as privileged as we are to have ethics resources at your disposal, leaders who are taking the initiative to, again, protect their workforce and think carefully about these choices. Some of you are already in the middle of the pandemic where it's hitting and the surge is on, and others have barely begun to even see a case or two of folks with COVID-19. So just honoring that we're all at very different stages, but obviously we're in this together, as we say. So let me see if I can forward the slides. Can you do that then? There we go. So what we're going to do today is talk about general pandemic ethics and principles, the impact that this will have or is having already on healthcare delivery. And then I'd like to suggest some modifications for chaplains in our practice, as well as some tips for how we can really support patients and families in the moral decision-making process and the impact of those decisions on them. And then I'll turn to my colleague, Tim, who'll talk about moral distress and moral injury of our providers, of clinicians, and strategies, again, that we can all use to support them, in particular, what chaplains can do. Next slide. So this has been out there, right? You turn on the news. If you're doing that, you can't help but do it. Some of us can't help but not keep turning it on, which maybe we should be limiting. And we see that our clinicians around the world are being faced with extraordinary decisions. Next slide. Closer to home, of course, the number of COVID cases rises daily. When we look at the graph comparing Italy, which has perhaps been the country most impacted until recently, the US is not far behind, and our surge, I just saw some data this morning, is really is starting to happen, especially in our large cities. We see it in New York City, of course, in New Jersey. This morning I saw Detroit, my hometown, is just being deluged and really struggling. And we are told that around April 7th, Chicago will see a similar kind of exponential rise in cases, and our hospital systems will be overloaded. Next slide. So in ordinary times, we think about medical ethics mostly on an individual level, what is right by this patient who is before us? We think about, again, aligning the plan of care with patient preferences, soliciting those, engaging in a partnership, a mutual decision-making, shared decision-making process. And sometimes that's the one primary physician and the patient coming together, the oncologist and the patient. At other times, it's the family as well as the clinician making decisions for the patient. But it's about that patient. Because in our healthcare system and in the United States more generally, we privilege patients' ability to make decisions for themselves, to have some degree of self-determination. So the value of autonomy is held up as almost absolute or inviolable. It undergirds such things as informed consent, right? The right to refuse life-sustaining treatment. Even if we think it's crazy, as long as you're not crazy, you have the right to do that. And it certainly upholds why we even think about advanced directives or have pecking order lists, depending upon the state where you live, to designate a proxy decision maker. So again, the ethical conflict that we mostly see is on the individual patient care level. And we see, again, a provider duty to beneficence, or the flip side, non-maleficence, do no harm, or do right by our patients, often conflicting on the individual level with what the patient wants or does not want, or what their family is asking us to do. So that's the normal state of affairs. Next slide, please. Pandemic ethics begins to look a bit like Selfies Choice, for those of you old enough to remember this movie. And my colleagues at the Hastings Center have provided a lovely 4-part model over here that shows kind of what the shift is that we're doing. We are shifting from, again, this individual model to, as the pandemic gets worse and we're in the most resource-constrained time, to where we're trying to privilege the population at large and the best outcomes for everyone, not just this person in front of us. Next slide, please. So this causes great tension for clinicians. If you imagine, just for any of us, we're so used to making decisions in this other way. So to begin to embrace a different framework is extraordinarily challenging for folks. We need to start to think in terms of optimizing the greatest good for the greatest number of people, as we say, hopefully delivered justly. And when we look at frameworks for crisis standards of care, for disaster planning, the goals that are listed for the state, for the region, sometimes if we have a leader who's helping us do this for the whole nation, is to minimize morbidity and mortality, to actually sustain a functioning society, and within that to ensure some degree of fairness. We treat like people the same. We aren't going to give the NBA basketball player access to the vaccine before my intensive care provider in the ICU. The principles that are lifted up and that support this framework, the first is a duty to care, which has always been ensconced in medical care, right? It's the same as beneficence, but now framed as a duty. But now the duty goes from the well-being of this individual patient to the well-being of all patients and to the well-being of the community at large. A duty to plan is the second main principle that is held up. And I, again, feel privileged to be in a place where we've been doing that for the last several weeks. Many of you are probably in hospital systems that perhaps didn't have the resources to begin to plan for the surge, to begin to figure out how we're going to protect our workers, some of the how we're going to fairly, justly allocate limited vents or medications. But a duty to plan is really part of what leadership and government should be taking responsibility for. The failure to do that, again, is part of what contributes to the moral distress and moral injury that Tim will talk about later. The duty to protect or a duty to safeguard our frontline workers, our first responders, and our healthcare providers is also important during this time. And that's a utilitarian value. This is a utilitarian framework that we're working with here. If our healthcare providers and our frontline first responders are not able to remain healthy, are not protected, we won't have a healthcare system, and we will not be able to provide the greatest good, the greatest healthcare, save the most lives for the most people in this pandemic. And then finally, a duty to steward scarce resources. And depending upon where we are, they are scarce. The scarcity varies. Core values that are held up during this time, again, are transparency. And transparency really has to do with being honest with folks out there in the world, again, about what are the frameworks that we're using when we're making these difficult decisions. It's not necessarily about getting it right. It's about being consistent, which comes a bit later in my list here, but also about saying we have limited resources. This is the reality. And here's again how, based upon conversations with important stakeholders and leaders and bioethicists, we have decided we're going to allot these scarce resources. Within that, of course, we are hoping to make decisions that uphold justice. And I'll just say this is incredibly challenging in the healthcare environment that we have inherited, because when you think about, for example, looking at comorbidities that people bring into the healthcare system when they then get COVID, those comorbidities, such as diabetes, heart failure, among other illnesses, are often unfairly distributed way before people even get COVID. So again, then will those same people who are often marginalized wind up being ranked lower when we have to make difficult choices, because frankly, they won't survive or don't have as much of a chance of surviving as somebody who doesn't come in already sick. Lawsuits have been filed already, I'm sure you guys are aware, on behalf of disabled folks, accusing systems of ageism. And so what we want to try to do, of course, is to specify that we're not going to make decisions based upon race and age and some other ethnicity, disability, but the ability to do that likewise is often constrained. Consistency, I'll just talk about for a second before I do proportionality. So obviously we want to apply these principles consistently, and having some kind of objective algorithms that physicians are using to, again, apply to patients who come into their care will be really important, along with some other less objective criteria for allocating resources. Docs are wired, let me just say this for the record, to provide care to the person that's in front of them and to advocate for their patient or their program. So you've got a lung transplant program. How does that program leader give up that attachment to their program if we need their ECMO machines or their vents for COVID patients, right? If there aren't going to be organs, or we can't spend our resources going to gather organs. Proportionality would ask that we, again, weigh benefits and risks as we look at each patient of moving forward with various plans. And this could include, again, a new factors, such as harm to your family at home in the benefit and risk ratio. Do we send a homeless person who's COVID positive but doing okay back out to a shelter where he might infect 20 or 30 or 100 people? Where can we send him if we don't send him there? Finally, reciprocity. What do we owe our first line providers, our first responders? What do we owe our healthcare workers who are putting themselves in harm's way? And this is debated in the ethical literature, and as we're putting together, as systems across the country are putting together their plans, there has been much debate about this, because of course we don't want to seem like we're just protecting our own. On the other hand, do we owe our providers something? Do we need to, again, ensure that they're safe and that they're motivated to come to work because we're going to support them and make sure they get the care they need if they get sick in the process? Next slide, please. So we're looking at three major resources: stuff, which is medicine, which are PPE equipment; space, beds, right? Where are we going to put people, be it ICU beds or general beds or hotels out in the community or cots in a bunker. And then, of course, staff is one of the most valuable resources that we have. And as the resources become more scarce, the ethical issues become more challenging along the way. You can see here, the Hastings Center has provided this lovely slide for us. Next slide. We're already seeing ICU bed shortages, and this very sobering slide predicts when each of our states will be seeing these bed shortages in the ICU and vents happen. And some quotes from our colleagues in New York City. I'm up to 27 patients in my emergency department waiting for beds, another 24 under evaluation. And we are seeing what they have seen is that they go from being moderately sick to suddenly crashing and being need to put on ventilators for this infection for a very long period of time in order to get well. Next slide, please. So who should be making these decisions? I said at the beginning that I'm lucky to be part of a team who is trying to lift the burden from the bedside providers. And we're doing that even as we want to empower clinicians to exercise their clinical judgment, and we'll need that, to set appropriate limits, to weigh benefits and burdens within their scope of practice. But when we start to have to say which person is going to get the vent, or are we going to send this person to a nursing home where they can have no visitors rather than going to their home, where they can be with their loved ones, but may not be as safe. Those kinds of decisions should not be on our providers. And so the recommended approach during a pandemic is to have an independent team making those decisions, setting guidelines, being in touch with leadership so that they are consistently informed of where the pandemic is. Are we at the triage level? What's our bed capacity? Do we have 20% of ventilators left? Where's our PPE stock? Again, this committee has that information at their disposal so that they can begin to provide guidance to the bedside providers. And the guidance would be, again, on how are we going to admit people? When are we going to say, we need the beds, we've got to get some of you guys out of here? When are we going to escalate to critical care? Who are we not going to offer critical care resources to? What happens when we have one person on a vent who's been stuck there for a very long time and their loved one is saying, keep going, and we have somebody else who we actually feel like we can save if they had that vent? How will we reallocate those resources, as well as other difficult decisions? And again, this is to minimize conflicts of commitment and potential bias, as I've said. This is not a new framework. When we think about the 4 principles of medical ethics, justice, I often call the stepchild of medical ethics. Justice is used when we're looking at other public health allocation questions, when we're looking at limiting personal rights. For example, if you have TB, you can't just wander around the community, you have to be monitored. It's also a framework that we are well aware of when we think of UNOS and organ allocation. While a bedside clinician might decide whether or not someone is appropriate for listing for an organ, it is the UNOS people who decide, again, who gets the organ first. So this is, again, not a new model, but one that pandemic ethics would strongly encourage us to embrace. Next slide, please. So the first scarce resource is our human resource and PPE equipment. And I said earlier, we have a duty to care for our patients, right? Our bedside providers, our clinicians, nurses, physicians, respiratory therapists, physical therapists, they have an ethic of care, and in some cases actually take oaths to care for their patients, to put their own their patients' well-being before their own. And for some, this means that when we are not supporting them in, again, doing that in a way that they're protected, they can get very angry. It's like, wait a minute, you set me up for failure here. You told me I have a duty to care, but now I can't do this. The flip side is some care providers, even if we are exercising the duty to safeguard their well-being, will feel as if they're required by this identity, right? This core identity they've taken to run into the burning house without their oxygen on. And so we have to balance some of those, the duty that professionals feel to care with the duty that we have to sustain the workforce. And I said before, that duty to sustain the workforce is based upon a utilitarian principle. If we don't have enough healthcare providers, we're not going to be able to save lives. Reciprocity, do we owe people something for, again, putting themselves not just in harm's way physically, they might get the virus, but exhausted, putting their families at risk. And then just pragmatically, how does somebody get up every day and come to work if we're not going to have their back when they get sick? And I know in our policy and many of the guidelines I've seen around the country from UPenn and Harvard and Yale and the state of Washington, there are really strong statements made that, for example, in the case of resuscitation, which produces aerosolizing, it's an aerosolizing process, and people who are responding to that code would be under greater threat of infection. People don't go in until they have their PPE equipment on, right? You just don't do it. And that might mean that that code is slightly delayed. Or we might say, you know, in this case, this patient is not, CPR will not give us the outcome that we want, which is to return circulatory function. And while the family says do it, we're not going to. We're going to limit their autonomy because we have to balance that over against the risk of exposing this whole team of providers and the expenditure of PPE equipment that we will need later down the road for other patients and other healthcare workers. What I'm certain many of you are running into, and I just find it staggering, is that these guidelines for how we're supposed to be protecting our workforce change every day, right? We were doing one thing last Friday, and now on Monday at our institution, we're doing something completely different. And it's not just based upon what's available, it's based upon, again, recommendations from what actually works and what doesn't work and what we're finding out. So I think chaplains, again, are used to living in this place of uncertainty, but even for those of us accustomed to this, it's very challenging. Next slide, please. So for patient care triage decisions, how are those made? Hopefully using consistent algorithms based upon both survivability to discharge, but also the duration of the benefit. And there are some scoring algorithms out there for different kinds of diseases that are being used. And then some people are using some exclusion criteria based upon, again, people who would die even if we tried to treat them, or those who would actually survive if we didn't treat them. So we're not going to bring you into the hospital even if you think you need to be here. We're not going to give you a vaccine or if there comes some treatment because you're good on your own. We have to help this other person. So I just listed a few of them that I've seen around the country. These are quite intricate and applied differently. And let me just say, controversial. Should we have any exclusion criteria? One's based upon age, for example. You'll see on here, age 85 or older. Should that be an exclusion criteria? Again, just to give you some example of what the triage decisions will be based upon and how they're justified. Next slide, please. So how, again, are we going to make these decisions? So decisions should never be made, I would argue, and all the ethics literature argues, on the basis of social characteristics, social worth, individual judgments about quality of life. And we're trying not to allot medical care on a first come, first served basis, but honestly, that's challenging because, again, kind of what wave of patients come into the hospital are also going to get treated first. And that sometimes then impacts who has more advocacy, self-agency, access to the ability to get to the hospital. Other criteria, essential social functions, reciprocity, life cycle. So that would favor younger people, pregnant women, 2 lives. And again, all of these would be developed in a transparent and accountable way. One of the interesting accountability things that's come up is that while healthcare providers and bioethicists will say there is no moral difference between withholding a ventilator and withdrawing it, the general public has a very different moral compass on that one. And then finally, the duty to care would uphold providing good palliative care to anyone who is dying from COVID and who is not receiving, again, the limited resources that are available. Next slide. What about advanced directives? This is where it shows up that we've not done a very good job with advanced care planning. So many of our institutions are really trying to encourage our primary care providers and providers for high-risk populations to reach out right now and begin to set the stage for, we're in a very different time, we have limited resources. You know, some people in the light of a pandemic like this have begun to think about their end-of-life wishes slightly differently. Where are you in that process? We've gotten a little pushback, thinking this might frighten already traumatized patients out there. On the other hand, it would be really good to know before folks came in if they would prefer to not receive things. The place where advanced directives are going to get tricky is when people have said, I want everything, I believe that life is matters no matter what, and where their advanced directives uphold that, because those will be at times overridden. Next slide, please. Other limitations we're seeing on liberty or autonomy: can't get in for your elective surgery, for routine tests, mammograms. We're switching, and we will switch from a standard of care, this whole long list of things that we have to offer patients and that Medicare says we have to do, to what are considered essential care or crisis standards of care. So maybe you don't have to take the pain score when someone comes in or ask them about their education level. Some, again, limits on where we'll discharge people to. Can somebody leave AMA? What's a safe enough plan? And then access to trial drugs, of course. And again, these are all grounded in these same moral principles we've been citing. Next slide, please. Visitor restrictions, big topic in the news. Again, this is where we just see the beginning of this. We have to be more concerned about the general population of patients in the community rather than this one patient and family. And I've quoted here from Vital Talk has some great resources for responding to some of these events and helping us as supportive care people reframe what's going on while validating the emotions that are coming up. So we now have a no visitor policy going on that includes when somebody's dying, and we're preferencing or trying to privilege or use, technology instead of people going into the room, especially for COVID positive patients, because again, we've got to use PPE equipment. Can we bring those outsiders in up into the hospital and protect our staff? Can we protect them? All of those things are leading to these restrictions. Next slide, please. So I just want to think for a second before I turn this over to Tim about the role of healthcare chaplains. I think we have to think a little bit differently about how we are advocates for patients, and think about the fact that we're advocating now for the community. We're advocating for human solidarity. We're advocating potentially for the survival of the human race. And be careful with what we promise when we, again, are at the bedside with families begging for things, because we don't want to promise what we can't deliver. So again, validating their anger and their grief, but reframing it in the context of this tragic situation where our hands are tied. This might include what we do with historically privileged religious claims to life-prolonging interventions, though I have begun to think that within most of our traditions, there are some frameworks we might be able to call upon to justify putting the good of all above the good of this one person and doing everything no matter what to prolong one life. Chaplains can, I think, also play a role in helping to reassure staff, patients, and families about the objective, consistent application of allocation criteria, that we're not discriminating against their loved one. And at the same time, monitor for biases that are still going to be built into our very rapid-paced emergency decision-making. And then finally, I just want to point out the social psychology of what I call tribalism. I've seen it a lot. Again, are you going to care for my family or my loved one? This patient right in front of me is much easier to advocate for than all of those people out there in the community. And so somehow, again, using the tools we have to hold up that complexity, even as we're helping to expand the framework of what people can take into account. Last slide for me. You can look at this later when you have access to these. This is again from Vital Talk, some ways to respond to some of the hard questions that patients and families will put around not being allowed in the hospital, not getting the ventilator, et cetera. Thank you.
All right, next slide. Well, good afternoon, everyone. My name is Tim Usset. I'm going to be expanding on some of what Jeanne shared, and particularly through the lenses of moral injury, moral distress, and burnout. So you see the definitions of moral injury up on the screen right now. These definitions really come from conceptualizing this construct or this syndrome through working with the military and veteran population. So I just want to say that these weren't necessarily explicitly developed for people working in healthcare, but now with this pandemic, I think some of these this conceptualization of moral injury, I think it hit close to the mark anyway, though it hasn't been empirically studied. I think it's potentially more relevant or closer to the mark now in light of the pandemic. And the definitions that I really want to hold up are really you see the second one from Jonathan Shea in 2014. He's the one who originally conceptualized it back in the mid-90s, but a betrayal of what is right by someone who holds legitimate authority in a high-stakes situation. And this hasn't been everyone's experience, but definitely, and this is global, not just in America, but across the world. There are definitely going to be people you're going to be caring for, whether that's staff, whether that's medical providers, or whether that's family members, or whether that's patients that have experienced someone in an institution that they hold dear or think that should look out for them, whether that's part of the healthcare system, whether that's part of their local or state government or their federal government in whatever country they fall in, that are going to have a sense of betrayal by people in positions of authority. And really those that are on the front lines of this are going to experience what we call these potentially morally injurious events. So either they perceive they're doing something that violates their own moral, ethical, spiritual code, they're witnessing something that violates those same things, they're feeling powerless to really address a really horrible situation. And again, there's that betrayal component that many are experiencing. Next slide, please. So I'm going to come back to these different dimensions of moral injury in a little later slide, but the things I want you to take away from this slide that we'll talk about later are the differences between someone who internalizes these types of potentially morally injurious events, so they're really more prone to blame themselves and feel guilty for something that they've done or that they haven't done, or something they didn't stop from happening. And then there's the externalizing presentation, so those that are going to blame the system, the government, the hospital, whomever it is, the medical team, for the type of event that they either experienced or witnessed. And then within these, it's really important to look at moral injury or this construct through the lens of a developmental model. And what I mean by that is that these types of situations, pandemic situations, really bring multiple moral contexts or levels of psychospiritual development into conflict with one another. So as Jeanne was talking about, we have this patient-centered care model where we're caring for the person in front of us. And then we have this utilitarian model during a pandemic that is aware of there are many other people who aren't in front of me right now. And the way that I choose to care for the patient in front of me is going to have big impacts in this area, in my specific hospital, in this specific population, about who I can and who I cannot continue to provide care for over the course of weeks and months of a pandemic. And lastly, I think it's really important to point out This is particularly on the internalizing side, so those that blame themselves for what happened. What is realistic guilt? So on the military side of the house, what is realistic guilt for someone who maybe committed a war crime or did something horrific, compared to someone who has a sense of guilt? So they have a sense of having done something wrong and blame themselves for a situation that was really out of control, as most traumatic situations are. And the way that they found a semblance of control in that chaos is to blame themselves, or believing that they had more agency to control the outcome than they actually did. Next slide, please. So moral distress has been more commonly studied within healthcare. It started within nursing, but it's moved on to include other healthcare professionals. And where moral distress, I think, is helpful in our clinical work is that in day-to-day operations of a hospital or a healthcare system, there may be a sense of, hey, this is the ethically appropriate course of treatment to pursue, but I'm not able to pursue it because of barriers, either internal or external barriers. And that's going to, for lack of a better term, going to be severely amplified during a pandemic. Again, thinking of that patient-centered care model, physicians and care teams know what the appropriate course of treatment is for an individual, but the internal and external constraints of policies put in place by their health system, of the overwhelming number of patients, the shortage of supplies, are really going to impact what they're able to do. Which brings us to another definition of moral distress, which is the experience of being seriously compromised as a moral agent. Which I think is going to be a pretty common experience for many care providers in the midst of this pandemic. Next slide, please. So lastly, I don't want to spend too much time on burnout for the sake of time, but burnout is something that's been more commonly studied in physician, but also in other professions. And prevalence rates of burnouts, you can read the definition on the slide, vary depending on what study you look at, from the 40% to the high as 80% within physicians in particular. And that was with the healthcare system operating status quo before a pandemic. And now I think that this experience of overwhelming exhaustion, cynicism, sense of ineffectiveness are probably going to increase in their prevalence during the pandemic and beyond. And lastly, again, there hasn't been good studies between moral injury as a construct and burnout. So this is the lowest level of evidence here in terms of if we consider me some form of expert on moral injury. My sense is that exposure to potentially morally injurious events will likely, as we study this more, we'll see relationships or associations with burnout from a causal perspective. So next slide, please. So now I want to spend at least a few minutes before we go to questions and answers on what do we do when caring for medical staff, whether it's physicians, nurses, CNAs, whomever, family members, patients that are impacted by the pandemic. And I divide them into kind of two categories, the internalizing and the externalizing presentation. With both categories, the things that I really want to hold up to you are the importance of having a shared sense of purpose, and we're all in this together. We're trying to address this pandemic together as best we can. And within that, there's going to be the paradox of validating the feelings that are there, but also the challenge of moving those individuals towards, I hate to say this, but better survival or better coping in the midst of an awful situation. So with someone who's presenting with an internalizing presentation of moral injury. So let's say you have a physician or a care team that's made the decision to remove a ventilator from one patient for whatever ethical reason. We'll assume they're acting within the guidelines of their health system, and give it to another patient. Someone who's having an internalizing presentation of that is going to blame themselves. I am at fault for removing the ventilator from this patient. That was my call. Even though it was their organization's call, the organization had a policy that they were following, but as the care provider, they're going to blame themselves for, it's my fault that person died. What if I would have chose to leave them on the ventilator, gone against policy, and maybe it would have been different. With that, it's really important to validate their experience, their anguish, their sense of suffering, their sense of horror. What we see when working with veterans on this side of things, or a similar situation, is that I don't necessarily move with folks who are presenting in that way with a forgiveness model. I don't argue with them about them being at fault or not at fault, but something that we'll do is sometimes is an empty chair exercise, either asking them to imagine speaking to a colleague who had been through a similar situation and what they would say to that colleague, or even in some cases where someone has died, I'll invite them to reflect, in this case, on hopefully the compassionate dead, on the people who died, and most oftentimes I see people, the vengeful dead do exist, but when people imagine what the dead say to them, it's oftentimes speaking to them with care and compassion. Or another, whether it's a colleague, you could also have them imagine what would a close friend say to them, or what would they say to a close friend. It's getting them, if we think back to these multiple moral contexts that are at play in a pandemic, we really want to invite them to consider alternative interpretations. On the flip side of that, we have the externalizing presentation. So this is someone who, and this is very real, you've all heard this, you're probably experiencing this. Healthcare workers, whether they're physicians, nurses, chaplains, social workers, whomever, who are really mad at their health system, at their local government, at the federal government for a failure to prepare for this situation. And they have that, they're experiencing that sense of betrayal. And because of that, it's really, really, really important to validate that sense of betrayal that they're experiencing, because it's very real. I hate to say it, but it's objectively true in some cases, in particular, more true in other places than some systems are doing better than others. But with validating that, you need to give them space to air that anger and that frustration, but you also need to invite space again for how are you going to cope, how are you going to do your job the best you can right now in the midst of this. Because unfortunately, we're really focusing on coping, we're really focusing on keeping healthcare workers able to do their job as best they can. And with family members, you could have both of these presentations too, which again, you can approach with similar ways. But for the sake of time, we're down to 11 minutes left. Can we go ahead 2 slides, Michael? I'll wrap up briefly and then we'll invite. So this is a bit of the what now. And again, keeping in mind that this is a marathon, attending to your own needs in the midst of this, attending to the needs of the care team that you're working with as best you can. And I know this has already been done and it's going to continue to be done, but I really say, remember, you're working, Mr. Rogers would say, look for the helpers. You all are working with the helpers. You're working with the people on the front line. You are people on the front line. Remember that you're a helper too, that you and your colleagues and your patients' lives depend on the care that you're providing them and the care that your care teams are providing them through the midst of this pandemic. So again, with there, I want to pause us and turn it over to Trace, who's going to facilitate some Q&A.
Thanks, Tim, and thanks, Jeanne. We have lots of questions, and we could keep you here the rest of the day. I'd love to highlight a couple of them and try to synthesize a few. Let me direct one to Jeanne first. Looking at decision-making, especially around the allocation of resources, are there models that you all are seeing that have begun to be developed that systems or individual institutions are using that you feel meet the kind of ethical standards that you've described?
Yes, there are. Can you hear me?
Yep.
Okay. Yeah, so I think that our colleagues at University of Pennsylvania, many of the institutions are beginning to implement those. And I think that we as a city of Chicago, we're working closely with our bioethicists and all of the hospitals around the area to begin to share resources and to think about how these decisions will be made consistently, not just within our own institution, but across the area, so that somebody who goes to the public hospital is not going to be underserved in a way that if they came to Northwestern, they'd get, better care. So I do think that there are attempts to do it. Now, when push comes to shove and the emergency room is busting at the seams, I haven't been in war before, but my guess is we do our very best, and we'll have to be quite forgiving of one another when we don't always apply these principles consistently.
Jeannie, let me just jump in real quick. Could you turn your webcam on?
No, trying. Hold on. Not sure I can do it. Sorry.
Jeannie, while you're working on that, let me jump and ask Tim a question. We had a couple of folks who asked if you are aware of any rituals that folks have developed to address moral injury that invite participants in to begin to address that through ritual.
Yeah, I would say the rituals of, and these are drawing from my experience in experimental treatments for moral injury in service members and veterans. But letter writing processes, I think, are really important. And again, thinking of something that can be done in the midst of pandemic, quarantine, and isolation. So the process of letter writing to one's higher power, the anguish that one is feeling, and then reflectively writing down or the sense of how one's higher power would respond to them. And that can be done in a variety of ways. You can use your higher power. Somewhat times you could say, write a letter to a trusted friend, write a letter to a person that's died, a childhood friend, and that could range from the practice of writing to them to tell them what's happened and how this pandemic and this anguish is affecting them in the real time, but also then writing to them how they would hope to live in the midst of the pandemic, and then continuing to write how might that friend, that higher power, whoever, speak to them or respond to them in the midst of what they've heard. So how would the imaginal friend in this case, what would they say to them about the care they've been providing in this pandemic, about the guilt that they perceive themselves, or the guilt they have relative to the agency they have. So those would be some of the things that I've seen have a lot of impact, again, with similar situations with service members and veterans, and that are easy to do in the midst of isolation and quarantine.
Great,
and
thank
if they
you.
want to go all in, I would say do it with a real-time friend, by Zoom, by Skype, by FaceTime, and do it that way. Have a real human involved.
Excellent, thank you. Jeannie, you used a phrase, privileging religious claims to medical interventions. A couple of folks had questions and asked if you could clarify what you meant by that.
Historically in our country, if you are part of a traditional religious community that has certain approaches to decision making or certain religious proscriptions about medical care, we have in our healthcare institution lifted those up to the highest priority. Whereas if it's just your individual preference, or we do our best to respect those, but they don't have the same gravitas, right? The same weight. And so I'm thinking in particular of Orthodox Jews, and kind of some of the very complex, and I will not attempt to even talk about proscriptions they have about when it's okay to actually remove life support, something of that nature, right? Or think about a Jehovah's Witness. Are we going to ask everybody when they're coming to the emergency department whether they are we going to get consent for blood products if they're bleeding out, right? Normally we would, because we know how important that is. In a pandemic, in a crisis, we may not. And it will, again, shift kind of how we think about respecting our patients' religious beliefs and preferences. So.
Adds another dimension to moral injury as well.
Yeah. And I think for chaplains, it will be particularly hard, because isn't that our job? That's where we're experts, and we know what those are, and we help people understand the frameworks, why it is that we can't stop now, right? And we do it for emotional reasons as well. I mean, we help them understand the grief of the family. It's just too soon. They need a few more days. And we won't be able to do that piece of our work as well either.
Sure. I'm going to ask one more question, and then Michael's going to give some technical stuff about where folks can get recordings and slides, and a couple announcements of some other upcoming webinars. The one other question that I would ask, and please know there's a dozen others that we could get to. We may ask if you all might be willing to take a few minutes just to write some responses to a couple of these, because I think there's some really rich content here. One of the questions folks asked is, we're beginning to hear about the possibility of blanket DNRs for people that are our COVID folks on respirators. What are you hearing? What do you know?
Okay, so I'm going to respond to that because we were misquoted in the Washington Post, our institution, the head of our department. There may be some instances in which resuscitation is not medically appropriate and futile. That will not be for all COVID patients, right? What if you have a young person for whom, again, resuscitation will bring back their circulatory function? It's an unexpected event. There will be some patients, however, because how COVID impacts pulmonary cardio functioning, where that intervention will not produce an outcome that any of us would want. And those are the circumstances in which we will need guidance from, again, a higher level decision-making team to say, this is where our institution or our region is going to draw the line. The other piece that will have to be taken into account there won't be a blanket DNR, but it will be a protection of staff so that if you're running to a code, you have to have your PPE equipment on. And that may mean, again, that some people do not receive cardiopulmonary resuscitation in as timely a fashion as they otherwise would have, or maybe not at all, because by the time everybody gets their equipment on, it will be futile.
Yeah, I think that many of us have been a part of something that is often called a slow code.
Ethically unsupportable.
Right.
Right.
So thank you both for your hearts and minds, for your labors, for all that you're doing, and for taking the time to share this information with us. Let me hand it back over to Michael to give a couple of announcements of a couple of things coming up and some details about where you can get the recording and slides.
Yeah, thank you, Trace, and thank you, Tim and Jeannie. This is, it's not just timely; it's crucial. So we're really grateful for your time and your wisdom here. As Trace said, this is being recorded. Everyone who registered for this webinar will automatically get a link to the recording. That'll be up in the next day or two. Really, it's just a function of when the webinar platform sends us the file. So everybody will get that. And it will also be available online at our website, chaplainsinnovation.org. So anybody can use it there. And please do share it around to anyone who might find it to be useful. Coming up this week, tomorrow, we're going to have another of the Chaplaincy Innovation Labs. We call them the Town Hall webinar, called Caring for the Caregiver, where we have folks that come on to talk about various things that have to do with trauma care, with crisis care. And really, it's an opportunity for chaplains to talk to each other, bounce ideas off one another, get some advice. It's just a nice, safe space for chaplains to sort of decompress and have a place to talk about what they're experiencing. So we do invite you to come to that. On Thursday, April 2nd at 1:30 Eastern, we're going to have a webinar called Distance Funerals, Complicated Grief, Gathering to Grieve During COVID-19. Zach Willett of LA Care Services is going to facilitate a conversation there on what does it mean to grieve when we can't be near one another, with funerals that can't have attendees, some of the exact same issues that Jeannie brought up at the beginning of when you cannot be physically present, what does that mean for grief and how can chaplains contribute to that? So that is what we are looking at for the rest of the week. I hope you will join us for those. Let me just thank Tim and Jeannie once again for their time. I think this is a really good, this is a great conversation to have, so thank you both.
Yeah, thank you, Michael. Glad to have been here with you all.
And everyone that was here, thank you very much for everything that you're doing. There's not much more to be said. This is an entirely novel time for us to be alive. So thank you for everything that you're doing. And until then, we'll wish everyone a good afternoon. Bye-bye.